Thank you, Ashley, and good evening, everyone. I'm Robin Toohey, Vice President Support Groups of the International Myeloma Foundation, and it's my pleasure to welcome you to tonight's teleconference, Sorting Out the Approaches to Relapse. Our speaker for this evening is Dr. Brian Durie, who is co-founder and serves as chairman of the International Myeloma Foundation's and also the Scientific Advisory Board. Additionally, he's chairman of the IMF's working group, a consortium of nearly 250 myeloma specialists from around the world. Dr. Durie also leads the IMF's Black Swan Research Initiative. So this teleconference tonight will focus on approaches to relapse to myeloma, and Dr. Durie will discuss what treatments you should consider if your myeloma has relapsed, with a focus on the latest FDA-approved drugs. Also, how to individualize treatment based on a patient's prior therapies, the length of the onset of relapse, and the FISH genetic risk status, age, and frailty score. The latest clinical trials, in particular immune therapies, will also be discussed tonight. If you have not yet accessed tonight's slides, you can do so at www.myeloma.org. At the end of Dr. Durie's presentation, we will open the lines for your questions. And please press *1 on your phone if you have a question. I'd like to thank our sponsors for their support for tonight's call, Celgene and Takeda Oncology. And it's now my pleasure to turn this call over to Dr. Brian Durie.
Well, thank you so much, Robin, and welcome to everyone who's participating in this teleconference today, sorting out the approach to relapse therapy. On my opening slide there, you have a picture of Los Angeles, which is pretty sunny today, although we're very, very concerned about winds coming through, as you've probably seen on the news. So if we go to my, what is slide number 2, then the next slide, the first actual slide, if we're going to talk about relapse, the first question is, well, what is relapse? And so for those of you who may have been diagnosed recently, there is always this concern about is disease responding, is disease stable, and is some new disease emerging. And so relapse is when there is indication of new disease. Now, that new disease can just be based upon some test results, for example, the myeloma protein in the blood or the urine. If that has dropped to a low or maybe even a 0 level, and then we start to find an increase in that level, then this can be what's called biochemical relapse, where there can be a 50% increase in the level of the serum myeloma protein, for example. That would be an indication of what we call progressive disease at the biochemical level. However, if in addition to that there are indications of true new active disease, such as new bone lesions, and then this is what we call clinical relapse. And so you could see that for clinical relapse, there's not much option. We would obviously be needing to select new treatment or change ongoing treatment. For biochemical relapse, there could be some option to watch or wait or decide how early the disease needs to be treated. And so if we go to the next slide, slide number 3, what are the current strategies in evaluating this potential relapse? Well, the first thing is to be aware that lab test results do fluctuate, and that lab tests may need to be repeated just to double check. And so the criteria for progressive disease is actually to have 2 tests, both indicating a 50% increase if there would definitely be progressive disease. And so be aware that sometimes lab tests do fluctuate, and so don't panic, particularly if a single lab test is just suddenly out of whack. Please wait for that recheck, and if that recheck does confirm there's an increase, well, that needs to be dealt with, but maybe that won't be the case. So for patients where there is a definite documented progression, The next thing is to decide, well, is early treatment warranted? Do we really want to nip this in the bud? And as you'll hear as I go through this presentation, there's very much a tendency to have that philosophy these days, particularly since we have a lot more very effective options, very well-tolerated options, and so we really feel that preventing new bone lesions, preventing new problems is good if we have an excellent option to be considered. Now, before switching to a completely new regimen, if for example, there's been ongoing maintenance, there could be a possibility to tweak that maintenance. If someone's taking Revlimid, lenalidomide, dexamethasone could be added, or maybe you could increase the dose of the Revlimid from a very, very low maintenance level to a higher level, if that is tolerable. But if that is not something that's feasible, then, and particularly if there's clinical relapse, then there would be a need to pick a new regimen. And so as I'm put in there, we would normally these days be preferring a triple regimen, so a 3-drug combo, to really try to do the best job in the relapse setting. And so if we go to the next slide, number 4, what are the factors that we are looking at? What are the tests that we do? What are the things that we talk to the patient about in making a decision about relapse therapy? So first of all, many patients will have received the Velcade, Revlimid, and Dex regimen as their first therapy, and we'd be interested to know how did they respond to that, and how long ago was that? And is ongoing maintenance being used, for example, Revlimid, or have they gone off of the maintenance? And we're also quite interested to know, was there a really excellent response, maybe even all the way down to no measurable disease with MRD negative, or perhaps a response, but maybe a partial response with a 50% reduction. And this can influence our choice of therapy. Obviously, if the response was not so good, we would be looking more closely at some new and different treatment. And then, in addition, we want to know, how did you tolerate the treatment? Was it well tolerated? Was there some issues where we might not want to use Velcade again, for example, if you developed some significant neuropathy and nerve damage? At the time of the initial bone marrow, did that bone marrow show abnormal chromosome test results? Did they indicate a 17p abnormality, a problem with chromosome number 17, a problem with chromosome number 1, with a gain? The G means a gain, so an extra piece on chromosome number 1, or maybe a translocation between 4 and 14. So these are things that would influence our choice of treatment and maybe the way that we would handle the relapse. And then, obviously, if this is your first relapse, that's very different than if maybe you've had several relapses, what we would call relapse refractory, where it can become more challenging to pick the best option. But as a start-off perspective, I think if we go to slide number 5, it's important to have a big picture of what we expect, the current expectations in 2019. And I give an example here, and there are a number of treatment options, and I just give some examples which use the Velcade, Revlimid, and Dex with autologous stem cell transplant as the primary treatment, followed by some Daratumumab combinations, and then also Elotuzumab later in the disease. And please understand, this is just an example, and I'm going to talk about what are a number of different options in each of those settings, the first relapse, second relapse, etc. But in this slide, what I'd really like to emphasize these days is that you can see the median or the average progression-free survival, or what is the length of the remission with each of those steps. You can see with the first therapy, 50 months, over 4 years. A little bit less than 4 years with that first relapse therapy with Daratumumab, Revlimid, and Dex, about 1.5 years with that next relapse, and around a year. And so what I did is I added all of those up, and you can see right off there that we're looking at a span of time in excess of 10 years. And so this expectation is something very important for you to have in your mind, and it's also an average expectation. And so some patients would even be doing considerably better than that, in fact. So if we go to the next slide, number 6, what are the broad recommendations to try to get that very best result? Well, I think that we're realizing treating the relapse early, if we can, is really the best way to get that excellent next best long remission. And using a triplet will give you that best result. And then looking in a personal way at the details in your case. Did you have good risk disease? Did you have an excellent response? Or maybe you have some other higher risk features that give us some caution and make us think about maybe some backup drugs that might be required. And so if we go to slide number 7, I just give a listing of the drugs that we're looking at to choose from. And you'll see there are basically 6 categories that we have. These are the major, what we call drug classes, which are available. The IMiDs, the immune modulating drugs, and those are the Revlimid and the Pomalyst. The proteasome inhibitors, those are the Velcade, Kyprolis, and Ninlaro, which is the by mouth option, which can be quite helpful. The alkylating agents, the older agents, the melphalan, you've probably heard about. Mostly high-dose melphalan is used as part of a stem cell transplant, which can be a relapse option. A second transplant can definitely be a relapse option. And then this type of drug called a D-acetylase inhibitor, Panobinostat, known as Faradex. And then, of course, the monoclonal antibodies, very, very exciting, the results with those. Elotuzumab, Daratumumab, and the new one, not approved yet, is Activism, which is similar to Daratumumab in being a monoclonal antibody against CD38. And the very new drug, Selinexor, which was just approved by the FDA not so long ago, a completely new type of drug, which I'll discuss a little bit. In considering relapse and thinking about it, it's important to be aware of a couple of things. And if we go to slide number 8, clonal heterogeneity over time, what I'd like you to do is to look at the different colors in the kind of pizzas of the pattern of the disease over time. It goes round in a circle from the left, from like 9 o'clock in the morning through noontime over until about 6 o'clock. And you'll see, if you look at the pie, the colors change, and this represents the fraction of the cells which are present, which have responded to the treatment or not. And you can see at the start of the treatment, there's a lot of red, but as you move around, you'll see that that red mostly goes away because that clone, that type of clone, is sensitive to the treatment and is mostly getting wiped out. But if you look all the way around, you'll see at the end, there's a lot of blue there. And now, if you look at the beginning, there's the very, very tiniest sliver of blue at the beginning. And what this tells us is that the myeloma can have a tiny, tiny bit of myeloma which is resistant to a lot of our therapies. And this is that little bit of myeloma which is the challenge for us late in the disease, which has been resistant to all of those therapies that you have used along the way. If we go to the next slide, slide number 9, you'll see that there's another thing to keep in mind, which is, in this case, you'll see on the left, you'll see a red box, which is identifying an area at the bottom of the spine, and that particular lesion in the bone there was tested and found to be a type of high-risk myeloma. It had abnormal chromosomes, it had GEP high risk, gene expression profiling high risk. But the point I want to make here is if you look at the other lesion over on the pelvic area, that was a low-risk lesion. And so what that means is that in the body there can be areas of myeloma which is high risk and areas which are low risk. And so this is why you take the treatment and maybe sometimes everything gets better except maybe one spot, which we might need to deal with separately, maybe give some radiation to that area just to finally clean it up. Or that could be the basis for a future relapse. So it's important just to be aware of that kind of pattern for the myeloma. Now, if we go to slide number 10, what I'm doing here is kind of starting to go through what are the lab results that we've seen with these different therapies, what are the clinical trial results, And so I'm starting with the monoclonal antibodies against CD38. Now, CD38 is present on the surface of the myeloma, and it's very strongly present there. And so using an antibody against that is very, very active against the myeloma, and it also recruits the immune system to additionally attack the myeloma. And there have been 3 important trials using monoclonal antibodies. The first 2, Pollux and Castor, used the Daratumumab as the anti-CD38, and then the third one, Icaria, used Elotuzumab, which is the new anti-CD38. And so what you can see, one of the most successful trials in recent years was this Pollux trial, in which you can see there was RD and then there's DRD. And if you look down, with the DRD, 22.4% of those patients actually became MRD negative in the relapse setting with this DRD combination, Daratumumab, Revlimid, and Dex. And you can see the average length of the remission was 44.5 months. So this was a very, very exciting result when it was first presented at ASH. Excellent deep responses with some prolonged remissions. And so this is why we look at that as an important option in that early relapse setting. If you look at Castor, very, very similar trial, and you can see that if you give the Daratumumab along with Velcade and Dex, you get that improved results, but not quite as impressive as with the Pollux study. And then if you go to the Icaria study, you can see also a benefit of adding in the Elotuzumab, but those patients, I would emphasize, are much, much later in the disease, and so these results are not really comparable, but gives you some idea of what have been the clinical trial results. But some exciting new trials have been coming along, which are important to think about when patients need therapy in the early relapse situation. And so if we look at a number of these in sequence, slide number 11, this is an important new combination, Carfilzomib, Dexamethasone with Daratumumab. And there has been a new trial going on called the Candor study, in which there was a randomized comparison with this. But this shows what we call the phase 2 results, which were published. And the main thing I'd like you to see here is that with this combination, this 3-drug combination combining and a very active proteasome inhibitor, which works against high-risk disease with Daratumumab, you really get excellent overall response, 84%, but also 79% in patients who are refractory to lenalidomide. So really excellent results. And down at the bottom, you can see that the 12-month remissions, 80% in standard risk, but also quite impressive, 62% even in patients with high-risk myeloma. So this is a good combination overall, but something to keep in mind in patients with higher risk features. If we go to the next slide, number 12, again, a very, very interesting combination using drugs which are active when other drugs have failed. In this case, pomalidomide instead of Revlimid, so that if Revlimid is no longer working, you can switch over to the next generation IMiD pomalidomide, combine it with Daratumumab, and again, you can see here in this single-arm phase 2 study, no comparison here, you can see very impressive ORR, which is overall response rate, 60%. And you can see some of those are quite deep responses, and also they did see some MRD negative, which means there was no indication of residual disease with careful testing. So another very good combination. If we go to the next slide, another monoclonal antibody, Elotuzumab, in the relapse refractory setting. If we look at eloquent number 2, which is the column on your left, you'll see that there was a clear benefit with the Elo-Rev-Dex versus Rev-Dex alone. This is particularly important in that you need to have patients who are still sensitive to the Revlimid to have this impact. And this is why we've been quite excited recently with a new study where the Elotuzumab was combined with pomalidomide. So Elo Pom-Dex rather than Revlimid-Dex, which has turned out to be remarkably active and is an important new option in the relapse setting. And so if we look at the next slide, number 14, this tries to drill down looking at the different combinations with the proteasome inhibitor. So if maybe Revlimid has been used and you need to look at a combination with a proteasome inhibitor, which would be Velcade, Kyprolis, or Elotuzumab, what are the results in that setting? And so if we start on the left, you can see if you use IRD, you have that benefit over RD. If you look at the ASPIRE trial, obviously Kyprolis, Revlimid, and Dex is better than Revlimid and Dex. And if you look over on the right, you can see with the Optimism trial, a very good word there that we like, pomalidomide combined with Velcade Dex is obviously better than Velcade Dex alone. And so these many studies you can see emphasize this idea that we have that the triplet is the way to go, provided it can be tolerated and managed in every way, including costs as well as side effects. We like to try to get that triplet therapy to get the very best results. So if we go to the next slide, number 15, given a choice, if we can, what would be the best of the proteasome inhibitors? And so there is an interesting study, well, actually a couple of studies that were published by Dr. Demopoulos in Lancet Oncology in 2016 and 2017, and basically they indicate that if you try to compare patients who've had Carfilzomib versus those that took Velcade, there was an advantage in the overall response rate and also the depth of the response in the patients getting the Carfilzomib. And so if we are struggling to have our best outcome, we would be looking, would be tending to look more towards Carfilzomib, which is Kyprolis, versus Bortezomib, which is Velcade. And so moving forward, if we go to slide number 16, another drug that you may have heard about called Panobinostat. This is commercially known as Faradex. This is another triplet, and you can see here, just like all the other studies, Panobinostat combined with Velcade Dex is better than Velcade Dex, although I would say not quite so impressive. The overall response rate, 60% versus 54.6, but nonetheless a clear advantage and something that is definitely available in the relapse setting, although toxicities can be challenging with that. And if we go to the next slide, number 17, a very exciting new drug that was just very recently, the most recently approved drug by the FDA, called Selinexor. And this is a completely new type of agent that blocks nuclear export. Basically, it blocks the export of tumor suppressors from the nucleus so that these suppressor proteins are kept in the nucleus and they inhibit the myeloma cell growth. And so a completely new idea. Selinexor is what they call first-in-class inhibitor of this type. And so if we go to the next slide, number 18, you can see that this was definitely active in very refractory disease, so what we call triple-class refractory. So it was active in patients who had failed on IMiDs, on proteasome inhibitors, as well as the monoclonal antibodies such as Daratumumab. So very important to have a drug like Selinexor that can salvage in that setting. Overall response rate 26%, so that this is something that can be available for patients who really need it. And it does have some challenging side effects, and I'll be glad to talk about that. And so it can be difficult as an ongoing therapy, but certainly can be a crucial bridge for patients to have a remission and move on to perhaps some other agents if need be. So if we move forward to slide number 19, I think it's helpful to look at the possible options, and you'll see I've listed them for first relapse. And you'll notice that these are triplets. They're 3-drug combinations. And just to guide you through it, on the left, these are patients who are still sensitive to Revlimid and Velcade, so lenalidomide and bortezomib. So in that setting, you have a lot of options. And in red, you can see Daratumumab Revdex would be good. If patient has high-risk cytogenetics, you might want to pick K or D. For patients who have become resistant to Revlimid but are still sensitive to bortezomib, then you would switch the Revlimid to pomalidomide, and then with the proteasome inhibitor, you could still use the Velcade, although you might want to use Kyprolis, again, if the patient had high-risk disease. If you move to the third block, these are patients who are resistant to bortezomib, and in that case, you would use a Revlimid combination, and you can see I've listed them there. And then on the far right, these are patients who are resistant to both Revlimid and Velcade. And obviously there you would need to use pomalidomide, and you would need to use Carfilzomib instead of Velcade and the like. So just to give you an idea, and I've tried to put as many as possible there, if I haven't put your current regimen or a regimen that you've heard about, it's just that you can see there are so many. And if we go to slide 20, the same is true. There are just so many different options in these different categories of sensitivity and relapse. And I'm not going to go through them all, but I think it will be helpful for you to reference these different categories and see kind of how we might pick one triplet combination, a 3-drug combination versus another. If you go to the far right here, these are the patients who were basically the type of patients treated in the Selinexor trial. These are patients who are refractory to both the IMiDs and the proteasome inhibitors, and there you're looking at some of the newer agents. And so if we go to slide 21, I thought it would be helpful just to focus a little bit here toward the end on 5 agents which illustrate where we are with some of the exciting new agents that we have available and what the results are showing and what we might be expecting moving forward. And I've listed them here, GSK, AMG, CAR-T, CELMoD, and Venetoclax, and I'm going to go through each one of those separately, and I'll explain what they are and what we have seen in terms of results. The target for these immune therapies, the top 3, GSK, AMG, and CAR-T, is something called BCMA on slide number 22, if you go to that next slide, B-cell maturation antigen, and it says here a near perfect target, and that's because this is an antigen which pops up on the surface of the myeloma, but is not present in the earlier lymphocytes. It is present in some other normal cells, but mostly it is limited and very, very strongly present on the surface of the active myeloma cells. So that's why it says a near perfect target, where you can target the myeloma but not damage other normal cells. And so if we go to slide 23, what have we seen using this as a target with the monoclonal antibody called the GSK-ADC? The ADC part means that in this case, the monoclonal antibody is combined with a drug. And so that means that once the antibody attaches to the myeloma, the drug is imported into the myeloma cell and assists in the destruction of the myeloma. So this is kind of a cool new idea, and I think people are excited about this GSK, but also this new concept of combining the monoclonal antibody with the drug. And you can see here in this particular study, the DREAM-1 phase 2 part 2, 89%, bottom left, you'll see 89% double refractory, Dara refractory, high risk. So this was giving good results in patients with quite advanced disease. And you can see the overall response rate, 60%, and good duration of remission. There is a strange side effect with this particular agent where you get some irritation of the eyes, but this seems to be well manageable. If we go to the next slide, it illustrates another type of an immune approach, which is called a BiTE, a bispecific T-cell engager. And this is an Amgen study with Amgen 420. And again, pretty striking results with a dose escalation. So people were pretty pleased to see the patients that were responding and staying in remission as you go from left to right here. And very, very interesting. Unfortunately, it seems like there is going to be a transition from this AMG 420 to a newer version, which is the 701, which actually is having an extended half-life in the blood. And so if we go to the next slide, BiTE formats in development, the first generation, which is the 402, is on the left. What we're going to be seeing now, I think, is what is called the 701, which is the half-life extended, which is the newer weekly infusion versus the continuous infusion, which was the cumbersome part of the 420 treatment. And I'm pleased to report that it seems that this transition from the 402 version to the 701 version is somewhat promising, and the early results have been seen with the 701 BiTE. Some of you may have noticed that I also drew attention to something called a BEAT, B-E-A-T, which is very similar, coming from a new company, and an agent called GBR1342 received orphan status a few weeks back, and I mentioned it in my blog from September 19th, actually. So if we go to slide number 26, this summarizes results with the CAR T-cell therapy, also directed against the same BCMA on the surface of the myeloma. And this one is called BB2121. And this is coming from the Celgene company in collaboration, actually. And again, when you see these bars moving off to the right, that means that the patients are in remission and moving forward to the right. And again, very promising results, which were published actually in May in the New England Journal. And so I think it's helpful if we go to the next slide, which is number 27, where you can see, if you look at these different types of therapy which are directed against the BCMA, you'll see that the one BCMA is against the CAR T approach, and that's why we have the elephant sitting in the little car there, because truthfully the CAR T approach certainly has been giving the most dramatic results. And so you'll see in the middle 11.8 months of remission in relapse refractory disease. However, the GSK was not too shabby with a similar length of remission, maybe not quite as high a response rate. And the bispecifics, we just need to wait and see against the BCMA what will be the overall results. And so this is what you're going to see, a comparison of these different approaches to target the BCMA. And so just to finish up, I want to touch on a couple of other agents moving through. Slide 28, this is an agent called Iberdomide. It's what's called a cell mod, which is very similar to just an IMiD, so similar to the category of Revlimid and pomalidomide, a little bit different. And you could see the impressive thing here is that the overall response rate of 31% in patients with refractory disease, including patients who had become refractory to the other IMiDs. So quite good to have that available. And then finishing up the next slide, 29, Venetoclax, which is a new type of drug going against something which is called BCL2, which is something that allows myeloma cells to survive. And so if you block that, then this results in the cell death and a very effective treatment. There was some concern about an ongoing trial called the Bellini trial, where there was some expected toxicities, including deaths, when Venetoclax was combined with Velcade and Dexamethasone, and this was linked to some increase in infection, although the real basis for the problems is not entirely clear. However, what has become clear that the studies have reopened, focusing on the patients who have the 11-14, because those are the patients that have high levels of the BCL2 and would be the most likely to benefit from Venetoclax, which is a BCL2 inhibitor. And so the Canobus trial is active and enrolling now, and that is comparing Venetoclax and Dex versus pomalidomide and Dex in patients who do have this 11-14 and have the high BCL2 levels. And so in closing, I've gone through a lot of different options, a lot of different therapies, and you can see it is crucially important for each patient to talk to their doctor and go through these options and look at their own particular situation. And so if we look at slide number 30, the key points. What is the timing of your relapse? Is this your first, second, or third relapse? And how has it happened related to, are you in active treatment, on maintenance, or off treatment? What was your response to the prior therapies? And how aggressive is the relapse? Are you having a lot of new lesions popping up, or maybe very, very slow changing where there could even be an option to monitor for a little bit? And then, of course, performance status. We need to know how well are you doing. If you're doing very, very well, excellent performance status, then that opens up a lot of options versus if you're having a lot of clinical issues where you're not so able to tolerate a variety of therapies. And so what are the principles once we get to picking the treatment? Slide number 31. We, as I've been emphasizing, we prefer to use triplets and perhaps combine two new drugs to get that best attack against the myeloma. Don't forget about transplant. Some patients have had issues with transplant, but some patients have gone through that first transplant without a lot of problems. And so several years later, if they had an excellent remission with the transplant, it's reasonable to consider a second autologous transplant. And of course, once you get beyond the approved drugs, then it is very, very reasonable to consider a clinical trial. And sometimes, especially with some of these really amazing new options coming along, the best option can be a clinical trial. And so this was certainly true, for example, with a number of these trials which incorporated Daratumumab. At the time, many patients were really failing, where the treatment was not working, and a trial with Daratumumab was what really made that major difference that they needed. And so in closing, let me just summarize the drugs that are available, the active drugs, which I've shown you mostly already. We have the older drugs, the alkylating agents, the melphalan. Then we have the bortezomib, the thalidomide, lenalidomide, sort of the mainstay of standard treatment, Velcade, Revlimid, and Dex, maybe the standard of care up front. And then you move to the next level of recently approved, Carfilzomib, pomalidomide, and the other ones that I have listed there. And then, of course, the exciting new future drugs, and I've touched on particularly the ones in red at the top, which are particularly exciting, and the GSK will be moving forward, hopefully for approval, for example, and also the BB212 CAR-T will be moving forward with the possibility of approval, and also is Elotuzumab. Selinexor already was approved. Venetoclax, the trials are still ongoing. And so my final message, which I think is extremely important to remember, slide number 33, in 2019, treatment for relapse can achieve long and good quality remissions. I showed you that first remission for relapse could be almost as long as the very first remission at the time from diagnosis. And so very significant remissions can be achieved, and it's quite important to focus on coming up with that very best combination to get the deepest response and try to have the best response and obviously the best quality of life that is possible to be moving forward. And so thank you for your attention on this call. Slide number 34, I'd like to again touch on our thanks to our sponsors, Celgene and Takeda. We couldn't do it without them. And so this is slide number 35, the final slide. This is obviously something that we do, that the International Myeloma Foundation, and in sync with the working group where we are working on providing guidelines for these different relapse options. We publish papers to guide the doctors to help you. So it's really a collaboration within the myeloma community that we foster to do the very best to help and to guide both you and your doctors. And so with that, I'll finish up, turn it over to the questions. We'll be ready for some questions now.
Yes, hi, Dr. Durie.
Yes, hi.
Yes, I'm Daniel Wade from Montreal, and I would like to know if you have any stats about relapsing after auto-SCT and versus allo-SCT.
Okay, so there's been both an auto and then followed by an allo,
right.
And then there's a relapse occurring. Well, I think that most of the options that we would use and consider are still available in that setting, and so it somewhat depends on what other agents may have been given in the past, but mostly there would be an option to consider most of the therapies that we would be open to. It depends on what the status of the blood counts are, and if there's a dependence on some of the immune drugs for the graft versus host. So that there are some things we need to think about in selecting the drugs, but most of the drugs, including monoclonal antibodies and a lot of these different newer things, would mostly be available. Occasionally, some of the protocols might have an exclusion, but mostly the options would still be available in that setting. Okay.
All right.
Okay.
Thank you very much, Doctor.
No worries. Mm-hmm.
Thanks.
Your next question comes from the line of Norma Jean Gallagher. Your line is open.
Thank you very much, Dr. Durie, for this excellent presentation. I've been noticing, as I read the outlines of different clinical trials, that for everything I've read so far that targets BCMA, right, there is an exclusion criterion for anyone who has received any therapy targeting BCMA. That right. makes me cautious about a decision where a therapy targeting BCMA might be recommended, because apparently if you've received one of those and then relapse, you're no longer eligible for the others, and that's the first three classes of new drugs that you included today. How would you consider sequencing those?
Right. Well, you've put your finger on a very important and delicate point, in fact. And so the first thing I would say is that it's in this situation, it's good to go to a center where those three anti-BCMA options are potentially available. In other words, a center which might have a CAR-T trial, a GSK trial, although those are mostly finishing up, and then a BITE or a BEAT trial. And so then the options can be evaluated closely. So as you know, for the CAR-T, there's a time delay in the processing to prepare the CAR-T cells. And so if there's any difficulty, if you selected, for example, to go into the CAR-T trial, if there's any difficulty or delay, then at that same center they could say, okay, well, we could go ahead and use the GSK or the BITE. And so I think that that's one important thing to consider. Moving forward, it seems like we will be less strict as we try to understand that if one of these anti-BCMA therapies has worked and then failed, maybe one of the others could work. But you could understand in a clinical trial, we're very hesitant to do that in the early testing period. And so this is an issue for sure, and you just need to think about it carefully. Obviously, using the monoclonal antibody and the BiTEs is more immediately available, what we call off the shelf, and could be given right away. And so you just need to look at the different points to try to select what maybe could be the best. Although fortunately, the results have been rather good with all of the options. So I hope it's helpful just to think it through a little bit.
Yes, thank you very much.
Yes.
You have a question from Robert Anderson. Your line is open.
Yeah.
Yes. If you have had 8 years of MGUS, and then you had the RVD treatment, then you had an auto transplant,
yes,
and now you are told that the disease is indolent,
yes,
does that change the logic of what you try?
Well, you've had the RVD, and then you had a transplant, and then you had a
yes, I'm just simply neither of those achieved remission.
And those did not give you a good remission.
Correct.
Okay. Yeah, so that does, as I was highlighting, that depth of the response, how good was the response with that first therapy, influences your choice, so that you would, in this instance, use my rule there, where you would go to a triplet, but maybe switch it out to give 2 new drugs, so that instead of Velcade, you might give Carfilzomib, instead of Revlimid, you might give pomalidomide, or, as I was indicating, you might completely switch and give Daratumumab. In your case, it would be Daratumumab, pomalidomide, and Dex, for example, which fortunately works well and has been approved by the FDA. So Daratumumab, pomalidomide, and Dex, for example, would satisfy that idea of 2 new drugs, really switching if that response was not good with the first therapy. Okay?
Okay.
All right. Something to consider. Obviously, all these things that I'm mentioning are intended to be discussed with your doctor, okay?
Oh, yes.
All right.
Thank you.
Okay.
Your next question comes from the line of Eben Foder. Your line is open.
Yes, hi there. I think all the options that you were listing in the presentation included Dex, and
right.
So I'm very sensitive to Dex.
Yes.
It causes physical, emotional swings,
right,
that really affect quality of life for me, and so I'm wondering, how much does not taking Dex affect my outcome on any particular regimen, and is there, what do you recommend in that case?
Right. Well, I think that Dex does add a little bit in all of our regimens. However, it can be okay to use a doublet without the Dex, and so all of these combinations, like from Velcade and Revlimid to Daratumumab and Revlimid, whatever. If you have to reduce or eliminate the Dex, patients can respond perfectly well, and so it's okay to talk to your doctor about that and just say, look, let's see if the doublet works in my case. And kind of go from there. I would say that very little doses of Dex can sometimes be manageable. We use 40 milligrams, 20 milligrams, but even as little as 1 tablet, 4 milligrams or 8 milligrams, 2 tablets, can be manageable, and it can give you that little extra benefit. So But it is reasonable to talk to your doctor about just eliminating the Dex or maybe just taking a tiny dose. Absolutely.
All right, thank you.
Okay.
Your next question comes from John Tour. Your line is open.
Hello, Dr. Durie.
Yes, hi.
Hi. Thanks very much for the presentation and your other work. I've been following this for a while now. I'm looking at pages 8 and 9 and not quite understanding what's going on.
Okay.
You're saying in page 8 that somebody's treated with lenalidomide and dexamethasone, and then they repeat that treatment at first relapse? The same thing.
Right. So what this gentleman is referencing is the slide which had what I call the clonal heterogeneity. This is the one with the colored circles where patients would get, this patient got len and dex, and then the treatment was switched. So the patient relapsed and got len and dex again, and then when they relapsed, they were switched to Carfilzomib. And so what happened is that different fractions of the myeloma were eliminated by the different treatments. And so basically what it means is that some of the myeloma gets eliminated, but over time the myeloma that is left is obviously not so sensitive to those therapies that have been used, because automatically the cells which are left were the ones that were not wiped out by the earlier treatments.
Okay, so they're doing a bone marrow biopsy on each remission then?
Yes. So this is not something that we would be recommending as a routine. This was a special study where they did this, and it helped us to understand what was going on. But this is not something that we would be recommending in your personal case. No, it's just an illustration of how we've understood that the treatments change the nature of the myeloma that's left to where obviously it's not so sensitive to the treatment that was used at the beginning.
Okay, so I started out with 1114, but at relapse I might not have so much 1114 again.
Exactly. That might have been very sensitive and wiped out, and so that's why we say if there's a significant problem, we might say let's recheck those chromosomes and study what's the pattern now to guide us.
Okay, great.
Yes.
Okay, I understand. Thanks so much.
All right, very good. Mm-hmm.
You have a question from Casey Edal. Your line is open.
Yes, I have a question about the future drugs, particularly CAR-T treatment. What we hear is that it's most likely will be approved by the end of this year. Can you give us some guidelines, including the AMG and GSK? What do you think is the potential availability for these for general use by the FDA?
Right. So I think that as far as the CAR-T, this is still like the $64,000 question. As you say, the CAR-T data are strong enough that there will most likely be an approval. My sense is probably not this year, maybe early next year, but in the coming months for sure. We're certainly hoping for that. But as I was saying, there are these manufacturing issues where it's not clear how that's all going to work out. The manufacturing facility for the BB2121 is in New Jersey, and so the samples come in there and are processed, and then hopefully they will develop enough of the CAR T cells that the treatment can be effective. But how that's going to be managed in terms of the recommendation from the FDA and the insurance companies, will this be fully covered in terms of the hospitalization if there are any problems with the treatment? There are a few issues that are going to have to be sorted out versus the GSK, which I said is kind of off the shelf, where you just go in and you would get the treatment. It's certainly a lot simpler treatment, and so that is most likely going to get approved as well. The BiTEs are going to be a little bit more delayed because Amgen switched from the 402 to the 420 to the 701. But so there's going to be a lot of detail to be worked out in terms of the rollout of these newer drugs. So I've just touched on some of the points, but certainly the CAR T is going to be more challenging in the clinical setting. You know, how many centers will truly be able to manage this, for example?
All right. Thank you very much.
No worries. Mm-hmm.
Next question comes from Nancy Colburn. Your line is open.
Yes. In one of your early slides, you showed us the median progression-free survival for induction, first relapse, second relapse, third relapse.
Exactly.
With
different
drugs
the different
that were
combos,
shown.
right?
Right, and then the first relapse was 44
or 44.5 months
progression-free,
right.
and so on, and then
right.
16 and 11. But you pointed out that were the drugs used for the second and third relapse, of course, were at the later stages. So my question is this combination that was used for the third relapse, isatuximab, pomalidomide, dex, has that been tried for first relapse?
No, not yet. I mean, so the idea is that it would be moving forward, and so right at the minute we don't know the comparison between using isatuximab pom-dex in that earlier setting versus daratumumab. One might guess that it could be maybe fairly similar. We don't know that yet, but you're right to kind of point that out. Yeah.
And what about the Revlimid pomalidomide comparison?
Right.
Are they about equally effective in whether it's first
right.
or second relapse?
Yes. I mean, one of the problems that we have is that all these different combinations have frequently not been directly compared, and so this is where there's a lot of personal judgment involved, you know, where we do have some comparisons, but then if you maybe didn't have that exact prior therapy, you know, how is it going to work for you? And this is where you just need to have that personal approach. And often we look to see, did an IMiD really work well for you? Did a proteasome inhibitor really work well for you? And try to focus on that so that we would move from Revlimid to pomalidomide to maybe a CELMoD. And then if the proteasome inhibitors are working well, we might move from Velcade to Activism to Kyprolis. So we use that to help us judge the best combination in a particular case, you know.
So is the refractoriness, I'm just noting that isatuximab and daratumumab are targeting CD38.
Correct.
So if the refractoriness were based on the target, on having the same target, then if the cells are resistant to daratumumab, wouldn't they also be resistant to isatuximab?
Absolutely.
Or is the refractoriness not based on the target?
Well, we feel that it is, to some extent, definitely based upon the loss of the target, so that the anti-CD30 activity is not is lost, and there are several mechanisms for that. And so, I mean, if you wanted to call into the IMF, I mean, we would be happy to work through that with you. But it's related to the loss of the efficacy against that particular target over time. Yeah. Okay, but very good question.
Thank you so much.
Very good question. So I think that if I'm correct here, we're pretty much out of time, and so I'm sorry if we haven't gotten to everyone's questions, but you can certainly call into the IMF or email into us, and we're glad to help out in any way that we can. And so thank you, and with that, I'll turn it back over to Robin.
Okay. Thank you, Dr. Durie. I found this extremely enlightening and encouraging and hopeful. We now know more about the FDA-approved drugs that are available to us as options, as well as our future with the clinical trials. So thank you for explaining all of that. It'll help us to have better conversations with our doctors about our own individual myeloma. Lots of good information happening. And don't forget, the replay for this teleconference tonight will be available early next week, along with all the other previous teleconferences. And again, that is myeloma.org, and simply click on IMF TV to look at all the different things that are there and available to you. And last but not least, if you have questions, the IMF info line has answers. Please call them. The number is 1-800-452-CURE, C-U-R-E. That's 2873. Missy, Judy, and Paul are happy to take your calls and help you through your questions, and they are available from Monday to Friday from 9 a.m. to 4 p.m. Pacific time. So once again, thank you, Dr. Durie, and a very special thank you to our sponsors that continue to make these valuable calls possible, Celgene and Takeda Oncology, and most importantly, thanks to all our participants tonight. We hope you found this informative and helpful, and to continue your key conversations with your healthcare team. We wish you a great evening. Thank you, everyone.